Okay, welcome to our document and reporting lecture. I'm going to share my screen so you guys can follow along. So documenting and reporting is chapter 18 in the F.A. Davis book. These are your key terms that we want you to know. These are the objectives for this chapter. So what is documentation, right? Documentation is going to be creating a record of your client's assessment and care. The client's health record permanently documents the care that we've provided in a chronological order, how your client responds to interventions and treatments, important facts about their health history. This would include the past medical history, their present medical illness, any examinations, tests, treatments, and outcomes. So the purpose of the written record, right? Number one, the biggest thing is communication. Our clientele has a multidisciplinary healthcare team that cares for them. And by keeping their status up to date, you are going to promote continuity of care. Continuity of care means that if I step away from my patient, somebody else should be able to continue with what I was doing without any issues or questions. So let's say I did a dressing on a patient. If I didn't document well the extent of what the wound was beforehand, then when you took over my care, you might have to assess and take down that dressing sooner than what's needed. So we want to make sure that we have good continuity of care and that when we leave what we're doing, somebody else can pick up with little digging and research and things like that. Quality improvement purposes, you're going to hear about quality improvement regarding the Joint Commission and our bodies of accreditation. We want to make sure that our patients are getting the best, most optimal healthcare possible. Some strategies that quality improvement helps is improvement of care, reduction of length of stay, reduction of overall costs. And it's really going to pinpoint the knowledge and practice gaps that we can address to just make things better and give our patients the most optimal care possible. For planning and evaluation of our patients' outcomes or our clients' outcomes, right? We want to provide documentation that's going to enable the providers, nurses, and other healthcare professionals to plan and evaluate the treatment and monitor your patient's healthcare status over time. And remember that this is a legal record. So if anything happens to your patient, this documentation will be under scrutiny by your legal experts to dispute healthcare things if they arise. So say you have a patient who develops a nosocomial infection, which would be a hospital-acquired infection, and you never documented, let's say it's a urinary tract infection with a Foley catheter. That's one of the most common hospital-acquired infections. And say you never documented, that you performed pericare appropriately for a catheter on your patient. You never did your HCG baths. You never did any of this stuff. Well, then they can further blame that on you. So you just want to make sure that same thing if your patient falls. If your patient falls and you never documented that they had non-skid software on, that their bed wasn't in the lowest position, their call bell wasn't in reach, that you weren't doing hourly roundings, they can prove negligence on your behalf. So you definitely want to make sure that you're documenting to cover yourself in case something arises. Our professional standards, right? The nurses, American Nurses Association, ANA, has our nursing scope and standards of practice. And your documentation should support that you're practicing within those guidelines. Reimbursement and utilization reviews. So a lot of times we as nurses, when we get into the field, we kind of push back on this. Not because we don't want reimbursement or proper utilization, But a lot of times to document to the best of our abilities, it takes time. And a lot of nurses will say, I want to be at the bedside with my patient. And, having practice, I understand that. But when we're talking about, if you do a dressing that takes you 30 minutes and it's going to take you another 10 to 15 minutes to document it, yes, it's stressful when we're doing time management. But the reality is that that needs to be fully documented so that the hospital can get reimbursed and therefore you can continue to get paid. And also, so perhaps your charge nurse would now need to change the acuity level of that patient because that patient requires more skilled nursing than perhaps they originally thought. So it's just really important that we document what we do, how we do it, so that way, the hospital gets the money that they need and that the patient's getting the appropriate treatments. And then the final one would be for education and research. And that kind of falls back into quality improvement a little bit, right? The record's going to provide that snapshot of what's going on with the patients. So that we're able to research maybe unfamiliar diagnoses, prescription reactions, prescription effectiveness, and other treatments before direct care begins. The healthcare record is also used regularly to gather data for clinical research. For example, if you have a patient, a lot of times they'll do cohort studies on all MIs. This is just an example of one that I did. So I was tracking for MIs in the emergency room, and then I would go back on a monthly basis and I would do a data collection of what time they got to the hospital, what time their EKG was done, what time their troponin resulted. And then we take all of that data so that we could then improve our quality care and eventually get chest pain accreditation, right? So education and research very much tie into our quality improvement. And then we go on to the importance of standardized language, right? So as a nurse, we want to make sure that nursing is visible. As healthcare costs escalate, it becomes necessary to demonstrate the value of nursing. That is to describe what nurses do and the outcomes that results. So standardized nursing terminology helps do that by making nursing care and its effect on patient outcomes more visible. It's going to support nursing research. So documentation systems that use ANA recognized terminology allow researchers to retrieve that nursing data for analysis and establish standards for the delivery of evidence-based nursing care. Such standards can help close the gap between the research, what the research shows to be the best nursing practices and interventions nurses actually use in practice. And then we have standardized terminology used for the electronic health record, the EHR. And this is really important because the computer requires standardized information that can be converted into numerical codes. And that'll help with your outcomes and auditing and things like that. So it's always important to understand the type of charting systems that you're going to encounter, knowing both the positives and negatives of each of those charting systems. And we're going to go through some of those charting systems now. So your source-oriented system has advantages that you can find information provided by each discipline very easily. The disadvantages of this is that data can be fragmented and scattered throughout the client's record. So you need to review all sections of the medical record fully to really understand the client's condition and care. It's especially difficult with source-oriented records to track treatments and client outcomes associated with a particular problem. The next is your problem-oriented systems. And these databases kind of provide a problem list of plan of care and progress notes. They are basically a common problem list for the input from all disciplines. Second is they're easy to monitor their client's progress because each problem is readily identified in the note. And the third positive is that each discipline has ready access of finding the other health members' team. It requires a cooperative spirit amongst healthcare providers, as well as diligence in maintaining a current database and problem list. So if you do not have good collaboration, this system can become difficult. Charting by exception is system documentation in which only a significant finding or exception to the standard or norms are documented. The biggest drawback to this is it can be a legal nightmare because you're basically saying that you have completely assessed your patient and everything is completely normal. Or the only thing that's abnormal is X, Y, and Z. And a lot of times with this system, with charting by exception, there is a lot of omissions of pertinent information. I've used this charting system before, and I've reviewed a lot of charts. The nurses who've used this charting system, and they'll just click through and everything is within normal limits. And then when you actually assess your patient, things are not within normal limits. Your patient, again, when you click that it's within normal limits, there's usually a very large detailed list of everything that you were saying that you were agreeing to. So if it's let's just say it's the GI system, you're saying that you have assessed from their mouth to their anus, you've listened, you've inspected their entire abdomen, you've auscultated all your bowel sounds, you've palpated the liver, you've palpated the spleen, you checked, for rebound tenderness to rule out, appendicitis. It's just a very extensive list. And, if you're documenting that you did all that and you didn't do all that, and then something comes up being abnormal, that's a liability, right? So these systems can be difficult. The next is just an electronic healthcare record system. The EHR consists of records that are entered via the computer. EHRs typically combine source-oriented, problem-oriented record styles, although the source-oriented system is most common. Advantages is this enhances communication and collaboration and improves access to the information. It can be very time-saving. It can improve your patient's quality of care. Your disadvantages are these systems are usually very expensive. They typically need significant downtime to update. And if you have power outages or system outages, a lot of staff have difficulty switching over. And then there's difficulty with change. So when they upgrade the system, sometimes there'll be change of where we document things, and that can cause a lack of cohesion. And there's also a lot of times a lack of integration. Most electronic health records are not integrated across the different departments. So it can make things hard. So I've worked with a hospital that had electronic health record system, and all of our specialty departments were on paper charts. So if your patient went to, let's say, interventional radiology, nothing was in the electronic health record for interventional radiology. You would have to actually go into a paper chart and actually look at that report. So that can be a drawback with that system. So your types of nurses notes. We can have narrative notes, PI, SOAP, focus, fact, electronic entries. So we'll review those. The narrative note is going to be you telling the story. It's going to require a great deal of time for writing all the details. Not many hospitals have a narrative system any longer, because Covenant has Cerner, Children's has Meditech, UT has Cerner. Other big hospital chains across the country have Epic, and there's T-System and tons of different systems. And most frequently, the narrative section is saved for different things. So like a story. If you had some type of family interaction that needs to be documented in the narrative. And again, it takes a great amount of time to write your narrative note. There's a lot of inconsistency among healthcare providers regarding this. Some believe it's not, if it's not charted, then it's not done. And then other documents only chart the abnormalities, and narrative notes make it very difficult to track problems from day to day. It can be lengthy, it can be disorganized. So if you work in a place that does narrative documentation, just make sure that you're crossing all your I's, dotting all your T's, doing your head to toe, and try to keep yourself organized so that you don't omit things. PI documentation is just your problems, your interventions, your evaluations. So your problems going to be data from your original assessment to identify appropriate nursing diagnosis or nursing concept. Your interventions are going to document the nursing actions that you took for each nursing concept or diagnosis. And then your evaluation is going to be documentation that the client's response to the intervention and treatments was either positive, negative, or any change. The biggest disadvantage for PI documentation is that it does not document the planning portion of the nursing process. There's no seamless flow of the client data, nursing diagnosis concept, and interventions such that can be seen in a nursing care plan. And I really don't know anybody that does PI documentation to provide an example of that. SOAP charting. SOAP charting can be SOAP and it can be SOAPier. So the subjective data is going to be the information that comes from the patient, client, family members. It's kind of like doing an assessment with words. And then your objective data is going to be your factual, measurable clinical findings. So this is going to be your hands-on touching head-to-toe assessment, your vital signs, your test results, and things of that nature. Your assessment is going to be the conclusions drawn from this subjective and objective data. So, good example. You have a patient who says they fell and they're having a lot of pain in their hip and they can't walk. That would all be subjective data, right? Their pain level is going to be subjective. The fact that they fell is kind of subjective. Now your objective data is going to be that, well, that one leg is a little shorter and the foot's kind of rotated out to the side. And lo and behold, we do an x-ray and we have a fractured hip. So your assessment at that point is going to be the conclusion from the subjective and objective data. So it's your client's problems or nursing diagnosis or nursing concepts. So if we have a fractured hip, that's going to be their medical diagnosis. Our nursing diagnosis could be, they're a fall risk, they have pain, they have maybe a perfusion issue because of, when we have a fractured extremity, we might not have the best blood flow down to that, things like that. And then your plan is going to be your short-term and long-term goals, right? So short-term goal might be that we're going to have some comfort. They're going to be able to tell you what their plan of care is. You can do educational and things like that. That's really falling into our nursing assessment and process, which we'll go over more in another lecture. And then if you do the SOPR, right, then we have the IER, and that's for interventions, evaluations, and revisions. So say you want to help your patient non-pharmacologically with pain, and you're going to position them, and you're going to give them an ice pack, and you're going to come back in 30 minutes, and you're going to evaluate, did my ice pack help? Did my positioning help? And then your patient says, you know what, the ice is really great, but I don't like this position. So then we're going to revise what we're doing for our patient. Okay. So next we have our focus charting. Focus charting, it's kind of columns that contains dates and times, and you're going to use that DARE format acronym, which is going to be data. So data is going to be your subjective and objective information. Your actions going to be your interventions, and your response is going to be how your client responds to whatever interventions that can do. Focus charting is attractive at first because it addresses the client's concerns holistically. However, critics claim that there is a lack of common problem list leads to inconsistencies in labeling the focus of the notes, and many cause difficulty in tracking your client's progress. The next would be our fact documentation. The fact documentation includes only exceptions to the norm or significant information about the client. It eliminates the need to document normal findings. And then we have our electronic entry system, which is a streamlined electronic process that make them more accurate and efficient and reduce the risk of human error. This frees you to do expert work that only nurses can do. Electronic documentation requires changes in how you document your work. EHRs change documentation formats from paper to electric. Documentation is done at the bedside instead of at the nursing station. Decisions-making process changes from gradual to immediate. As a nurse, you'll most certainly need to have computer skills. Documenting on the EHR system uses an associated documentation form. Progress notes may be documented electronically in pre-built note formats. In some electronic systems, you may still need to write progress notes on linear paper and a narrative, SOAP, PI, focus, and fact formats. Transitioning from paper to electronic documentation can be challenging. Transitioning back is even harder. It'll take you a few days to get used to your computer systems where things are located. So definitely take time in your clinical to go through this stuff so that you're comfortable with it. This is a question. Answer. So documentation forms your nursing admission assessment. So your nursing admission assessment is always creating a baseline assessment, and it's essential because it can be used as a benchmark to monitor your patient's change. It provides information about the client support system and helps forecast future needs. It contains critical information about presenting illness or reason for admission, vital signs, allergy information, current medications, activities of daily living status, your physical assessment data, and you always want to start discharge planning at time of admission. The admission assessment would not contain a diagnosis, but would contain those physical assessment findings. It would not contain medication orders. It would not contain follow-up of medications. It would contain information like your patient is awake, alert, and oriented, where respirations are cleared unlabeled. And to put a better example on that, right? We have a patient who comes in and we do their head to toe assessment, and let's say their breathing is even and unlabored. So That's great. And then you get the past medical history that they have sleep apnea. So, as a nurse, right, forecast future needs. You know that, okay, right now my patient's breathing is good, but in the future, tonight, they're probably going to need a CPAP. And I don't have a CPAP order. So, I need to quickly think and figure out what we're going to do to make sure that they have their CPAP tonight. So, that's how that forecasted future needs is. Your discharge summary, general principle in nursing is that the planning begins on admission. Therefore, discharge needs should be evaluated when the client first enters a healthcare facility, especially in our acute care facilities like a hospital. The summary is completed when the client is transferred within the same organization, transferred to another facility, or discharged home. The discharge summary may be multidisciplinary document, or each discipline might write a separate summary. The forms are different depending on the organization. So let's say you have a patient who comes into the emergency room, right? And going back to the hip fracture, they have a hip fracture. When that patient gets admitted, and that nurse that's admitting them knows that, well, hip fracture, this patient's not going to go home, they're going to be going to rehab. So we got to get that consult to case management so that they can start getting those approvals and getting things lined up. And then for that patient, that multidisciplinary, they're going to need a discharge from their surgeon, their orthopedic surgeon. They're going to possibly need additional discharge information from maybe a physical therapist that's already at the hospital to give them further direction going forward. If while they were there for their broken hip, they had things going on with cardiac or respiratory or whatever discipline, you might have multiple documents that your patient needs to complete, and then you have to provide education on each of them. If that makes sense. All right, so flow sheets and graphic records. Flow sheets and graphic records allow you to see patterns and change in a client's status. Cerner, which is used locally, and I believe Meditech 2, allow you to pull up a vital sign page and you can see where your patient was at 8 o'clock, where they were at noon, and you can trend those. Same thing with I&Os, how much they put out last night, how much they put out today. You know, if you notice that there's a big difference, then think about how much did they take in, and you can compare those at a glance. Some hospital systems have upgraded systems where you can actually plot out a graph, and you can get, linear graphs and all this fancy stuff. And you always want to make sure that you're recording your I&Os accurately because they are very important. So your medication administration records, remember that you do not want to do go-arounds, or you want to follow whatever policies and steps the hospital you have does. Your electronic medical records, the MARS, your medication administration record, you're going to make sure that you document accordingly to the times that you were given, whether it was scheduled or unscheduled, if it's continuous, as needed, stat, and so on. Your drug allergies are always noted on your MAR, whether it's paper or electric, and make sure that while you're giving a medication, you confirm the allergies on the MAR are accurate. If the client refuses, the refused medication should be noted on the MAR as well. Your organization's policy will determine how that goes. You also want to make sure that if you omit a medication or a medication is delayed for a reason, that you chart that accordingly. If the client is off the unit getting dialysis and that's why their medication wasn't given, or why it was delayed, you need to make sure that that's documented according to your facility's policy. If you need to reschedule a medication, you need to know the appropriate steps to reschedule the medication. Is it a reschedule for a single dose? Is it a reschedule that's going to be something permanent? All of that stuff. You'll have patients who the hospital standardly does Synthroid, levothyroxine, those thyroid medications at 7 o'clock in the morning. 7 a.m., 7 a.m. And then you might have a patient who says, I take my medication, my Synthroid at night before I go to bed. Some patients do. So in that case, that could be a permanent reschedule of the medication. So you can read through that in your answer. All right, so Kardex or client care summary. Paper Kardexes are usually kept together in a portable file in a central location of the nurse's station to allow all team members to access the client's summary of information. Each client has a separate electronic summary screen. All authorized members of the care team can access the electronic care summary at the same time, whether they're away from the client or even outside the organization in a remote location, depending on the institution's permission for access. If it's a paper Kardex, obviously it would not be allowed to be, there'd be no way to access it. So our Kardex in continuation, you can have your IV therapies on this, prescribed treatments, wound care, a summary of medical medications prescribed, and special instruments. So then we move on to our integrated plan of care. Also IPOC, and IPOC maps out day by day the client goals, outcomes, interventions, and treatments for a specific diagnosis or condition from admission to discharge. Lab work, diagnostic testing, medications, and other therapies are all included in this pathway, as well as standardized interventions captured in the plan. And the IPOC helps administrators predict length of stay, monitor cost of care, and can assist in staffing. Other advantages of these is that they eliminate duplicate documentation, they increase team effort, and enhance the nurse's teaching about what the client can expect during the hospital stay. An occurrence report, also known as an incident report, is a formal record of an unusual occurrence or an accident. This is organizational report, and it is not part of the client's healthcare record. So every hospital that you work at is going to have their own way of how you handle an occurrence report. If a patient falls, you have to document in their chart that they fell. You do not document in their chart that they fell in the meeting occurrence report. You should report all errors, even if there was no adverse impact on the client. It's important from a safety standpoint and for improving your institution's quality of care. And an example of, how we got to those sound-alike, look-alike medications was because people documented even those near errors. You picked up Cardine and it was supposed to be Cardizem, and you got to the bedside and you didn't give the Cardine, but that would be like a near miss. And we should do occurrence report depending on your facility near misses too, so that they can say, okay, what do we need to do so that instead of pointing out Cardine, they only pull out Cardizem. When completing an occurrence report, you need to be as accurate and as clear as possible. You need to make sure that it has the client, the date, the time, the location. You need to describe the incident. You need to quote if there was quotes. Do not draw conclusions or place blame. So what I mean by drawing conclusions is you don't know we found the patient on the floor, right? Patient was found on the floor. Do not say the patient fell to the floor unless the patient says, I fell. And then you quote them, patient states, I fell. And you want to identify any witnesses to the event or any equipment involved in the event. So if your patient was, found on the bathroom, on the floor, and the support rail is fallen on the floor, you might want to add that equipment involved on your report. Another question. So home healthcare documentation, whether your home healthcare documentation is done on paper or electronically, the following should always be included. You're going to want to have your assessment highlighting any changes in the patient's condition. You want to make sure that there's any interventions performed, such as wound care, teaching, dressing, and so on. The client's response to the interventions that you did, any interactions or teaching that you conducted with caregivers, and any interaction with the client's primary care provider. Long-term documentation. There's legal requirements to protect older adults, mandate that you report any changes in the client's condition to the primary care provider, as well as the client's family. You want to document your report in a narrative note on paper or in the appropriate areas of whatever electronic format you use. If you're caring for a client receiving Medicare reimbursement services, such as IV therapy, wound care, rehab service, documentation is required with each shift. In addition, a summary written by the nurse must be recorded weekly. So your long-term weekly summary is a summary of the client's condition, evaluation of the client's ability to perform their activities of daily living, the client's level of orientation and their mood, their hydration and nutritional status, any responses to their medications, any treatments provided, and then safety measures used, like the bed at lowest position, non-skid socks, belt, bed rails, and things like that. Moving on to reporting. Reporting is a method to inform other caregivers about your client's condition. You can have nurse to nurse, nurse to provider. You should also do nurse to your unlicensed personnel or nurse to LPN if you're working with that type of healthcare team. Your communication is vital, related to the client's status and plan of care. Reporting is always a communication pathway, and we want to make sure that we're doing vital information. So your handoff report could be verbal. You could do walking rounds, and you could do audio recorded. I've worked at one facility that did audio recorded report, and is definitely not a preferred method because it doesn't give the oncoming staff member a chance to actually ask questions. So if the nurse recording left something out, we're kind of out of luck, or you're calling somebody. No. The overall purpose of handoff report is to alert the next caregiver of the client's status or recent changes in the client's condition, and to discuss planned activities, tests, procedures, or concerns that require follow-up. Things that we do not report off are typically if like routine hygiene was done, insurance status, things like that are not required for that. So one type of handoff report would be your IPAS, which is illness severity, patient summary, action list, situation awareness, and any plans, and then it's synthesized by the receiver. And then your SBAR is most commonly used. That's going to be situation, background, assessment, recommendation. Your PACE is patient problem, assessment actions, continuing changes, and evaluation. And Cuban is confidential, uninterrupted, brief, accurate, named nurse. And keep it Cuban should be how you're giving report, right? You want to make sure that report's confidential. We do not want lots of interruptions because once we get interrupted, we lose our train of thought. It should be brief and succinct. There doesn't need to be a lot of extras. I've had nurses that tell me 45 minutes about the family and cannot recall what their patient's breath sounded like. And that falls into accurate. You want to make sure that you're accurately providing the assessment and what's going on with your patient. I think one of the funniest reports I've ever got was that they told me a patient was a bilateral amputee, and it turned out that when they were in the emergency room and that nurse was caring for them, they were just sitting and being stuck. And you always want the name of that nurse, right? First name, last name, proper documentation. Just because the person who gave you report, that doesn't mean that that's actually the nurse that was caring for them. So you always want to get the name of who gave you report. Transfer reports. So transfer reports can be transfer between units, between hospitals. You want to make sure that you get that contact information, because the patient could arrive and they could have legs. And not that you're going to call the nurse to call them out on that, but you definitely want to, say the patient's coming and they're complaining of a lot of pain, and they said that they were going to medicate them before they came up. So you want to make sure, like, hey, did you medicate the person? Because I don't see it in the chart you sent, and you might not have access to that aspect of the chart. Client demographics, diagnosis, reason for transfer, right? Maybe you work at a small hospital, you don't have critical care services, so that's why you're transferring a patient. Family contact information, summary of care, their current status, what medications, treatments, tubes, drains, things like that. Wounds, open skin, if there's any advanced directives, code status, and things of that nature. Isolation is a big one. Sometimes, depending on the system, the ER chart might not pick up that patient's normally on isolation from MRSA. So, you might receive a patient and find out, a few hours later that they should be on isolation. It happens, it's not optimal, but, ask if they don't tell you. And again, right, that's the last line. As the receiver, you need to make sure that you ask any questions. You need to make sure that you're listening to what the person is saying, so that you're not asking questions of things they've already told you, but you need to seek clarification if something's missing. So orders are part of the chart. They're part of our documentation. We can have verbal orders. Verbal orders are pretty much only if we have an emergency, such as you're doing CPR on a patient and the doctor says, I want 1 milligram of epinephrine. And you need to make sure that you say, okay, you want 1 milligram of epinephrine, and say it back to them, because maybe they really didn't want epinephrine. Maybe they wanted atropine. So you need to make sure that you clarify your verbal orders and read them back. Verbal orders at some point still need to be documented, and they need to be ordered. Unless you work in the emergency room or critical care, you're probably not going to have verbal orders. You could definitely have telephone orders. As a student nurse, you can take note orders, so do not forget that. But your telephone orders, always make sure you know the physician that you're speaking to, so that way when you're writing the order, entering the order, you're putting it under the right provider. They have to co-sign the orders. And you always want to make sure that you read it back. Reading it back safeguards your patient. There are many physicians that do not want to be bothered hearing you read it back, but you should read it back. Again, going back to those sound alike, look alike medications, you could have heard clonidine and you really wanted Klonopin, and there's a big difference between those two drugs. One is going to change their blood pressure, and one's going to, is a benzo, is going to make them sleep. So you just want to make sure that you safeguard your patients and enter those correctly. So a little bit more about those telephone orders. You only want to do a prescription or an order that you actually heard yourself, right? This is not, hey, I'm going to lunch, but the doctor said the patient could have 650 of Tylenol Q4 hours. Can you put that in? You do not want to put that in. And you want to make sure that they make sense, right? So Again, you guys are newer and you might not know all the drugs, but if they say that they want 2,000 in Tylenol, well, that's high. So, and you want to make sure that it makes sense for your client's condition. Think about the blood pressure pill and the anti-anxiety pill. Like, if your patient's not anxious, they don't need a blood pressure pill, or if your patient's blood pressure is normal, they don't need it. So use your critical thinking. Again, repeat it for accuracy and spell unfamiliar names and pronounce the digits separately. So you want 10, right? And that's just going to help to make sure that errors don't occur. Most hospitals are pulling away from them, but they still have. And again, more, right? Telephone orders, because they can happen. You want to make sure that you document the date, the time, the text, the provider's name, you sign it, and they have to co-sign it within 24 hours. So questioning an order or prescription. Again, most hospitals these days, the physicians are not writing on an order sheet, but downtime happens and then you have to put in orders after the fact. A lot of the hospitals that I've worked at, usually the provider writes the orders, it gets scanned down a pharmacy, the pharmacist enters them, and they can do the communication if something's wrong. But if you're the one putting it in, if it's illegible, you got to contact the doctor. Or if there's improper zeros, improper abbreviations. And one of the things that I was always told was, if you're looking at a medication and you're having to pull up multiple vials to make one dose, consider that something might be wrong. Okay, if you only have, let's say, metoprolol 25 milligrams, and that's all your floor has, and the doctor orders 400 milligrams of metoprolol. Okay, well, they make 100 milligram tab, but you guys only have 25. So you really think the doctor wants you to pull up, what would that be, 16 tablets? That's a lot. So if things just don't seem right, it just doesn't make sense, put that call out to verify, okay? So documenting client care, you want to be familiar with the facility forms, you want to chart in the required format, you want to document all aspects of the care, you want to make sure that you're accurate, you're complete, and you're consistency. I always want to stress to students that when you're documenting things like refusal of care, you want to make sure that you document that it wasn't given. You don't want to document things like the patient was uncooperative. Because if anything gets called into question, then you need to specify how the patient was uncooperative. Rather, if you want, you can quote the patient, including would then give you that uncooperativeness without actually you saying that they were uncooperative. So again, you can either say that the client refused the care, or the client declined the care. I actually worked at one facility that they did not want you to use the refuse care button. They wanted you to say that they declined, because we had a very highfalutin person that got very upset that they refused because it had a bad connotation to it. So just, be familiar, and, they refused, they declined, and don't add things like they were abusive, uncooperative. If they slapped your hand, you can say, patient refused medication and slapped my hand. So your guidelines for paper healthcare records. I know a lot of people say, I don't need to know, paper healthcare records because we use a computer system. Computer systems go down. So you need to make sure that when you're using paper charts that you maintain confidentiality. And just like you wouldn't leave a computer live in a patient room, You wouldn't want to leave a paper chart in the patient room. You want to make sure that you're using the correct form. So if you're doing paper charting and you need to get a physician order, you need to make sure that you have the right paper order form. Some places have it in triplicate, some have it in duplicate, some have it in single. You need to know. You need to make sure that it is marked appropriately with the client's name and their ID number. Hopefully, if your system goes down, you still have patient labels. If you don't have patient labels, then you need to make sure that each page of that chart is identified appropriately. You want to make sure that it's legible, it's neat, and it's organized. If you work in a hospital, that when you move to paper charting, they have the flow sheets where you just have to click things. It makes it easy to be more organized. But if all you have is a narrative note, I would suggest doing a rough draft before you do your final draft. You always want to use black ink for your handwritten notes. You do not want to leave blank lines in your narrative because that can provide somebody the ability to go back and add, which you do not want. If you make something incorrect, you draw a line through it and you initial it. You do not use whiteout or anything like that. You don't want to block it out so much that what was underneath can never be seen again. So like no Sharpies through it. You want to make sure that you sign all documentation with your first name, last name, and your credentials. And you want to make sure that you only use approved abbreviations. So if it's been a while since you've used abbreviations, and you're not sure, either look them up or don't use them. Write the word count. Guidelines for your electronic healthcare records. You want to make sure that you know how to use the equipment. You want to make sure that you frequently save entries. You want to follow organizational guidelines for rolling computers down. And why I say that is, recently one of our local systems had an extended downtime period. And a lot of nurses are used to maybe an hour being down or 2 hours being down. So when they had the big downtime, they were expected to know how to function. And a lot of them didn't, because when the computers would go down for schedule maintenance, they would just wait to do all their charting. And therefore, they had no idea what to do when it went down. So you really need to be cautious about that. You want to maintain your confidentiality, right? We're not going to share our passwords. We're not going to leave our screens up. And then we're going to ensure that the data is secure. Computers are placed at a high risk of breaching of patient confidentiality. So you want to make sure that you do not stay logged in after you document or leave the system. You want to definitely make sure that you lock out that computer or tap yourself out so nobody can get in. This is just a bureaucratic reasoning that you can run through on your own if you want. And that is the end of this lecture. I hope it helps.